Good afternoon on behalf of Diabetes Awareness and You. As you all know that tomorrow we have our 8th day DIC. This year due to some unavoidable circumstances we are doing the 8th day DIC virtually. And customarily there will be a pre-conference workshop. Today we have our pre-conference workshop with two legends actually, true stalwarts among us. One is Professor Edward Jude from UK. Already we have Jude with us, and Dr. Ghanshyam Goyal. All they are very famous in the diabetes food field. So I welcoming you, both of you, Dr. Ghanshyam Goyal, sir, from Kolkata, and he is famous in India also. Sir, please here. And Professor Edward Jude. Warm welcome on behalf of Diabetes Awareness and You. So I am handing over the mic to Dr. Goyal to carry forward, sir. Thank you.
Thank you, Indrajit, and thank you, Day, for inviting me. So before we start, I welcome Professor Ed Jude. Professor Jude is a well-known, I will not say personality, he is a well-known face across the globe. Not in UK or in India is the second home, but I'll say I'm proud to say that he is from Indian origin. So we are lucky, and he is now at the national NHS at the Thameside Hospital, NHS Foundation Trust. He is a professor of medicine, and he's having renowned and tremendous work in diabetic fit, especially, and he was the president of our chair of the ESD, Diabetic Food Study Group, and his work has been cited thousands of times all across the globe, and people are taking the inspiration from him to work on diabetic foot. He is one of the biggest name across the globe in the field of diabetic foot, and I think we are lucky that today he is here to conduct the workshop on diabetic foot, and I think you are going to learn a lot of things. Even a very small tips are going to benefit you all. And so now I invite Professor Jude to start the workshop. Yes, Professor Jude, please. Give a big hand for his talk.
Thank you, Ghanshyam. Thank you, Indrajit. Thank you, Sujay, who's still not here, for the invitation to be here at this conference, and thank you for those very kind words, Ghanshyam. I've known Ghanshyam for many years. We've done a lot of work over the years. We've done a lot of studies, few publications together, and hopefully some more to come. I also would like to thank Rekha for coming today. I've worked with Rekha in this conference with Day last year and a few years ago. She's a very excellent podiatrist, and I've learned a lot from her also. So there's a lot we can learn together today. So what we're going to do today is look at diabetic foot, which is the push that we're having within Day to prevent amputations, prevent ulcerations in people with diabetes. Something that is very close to my heart because we are seeing a lot of amputations globally, also in the UK where I come from, but also here in India. Something we can prevent. We can prevent a lot of amputations if people get right foot care at the right time and intervention is done in a timely manner. Because what we're seeing at the moment is increasing number of people with diabetes, not only here in India, but globally. And I understand that what we presumed would have been about 57 to 60 million people with diabetes, the numbers actually have increased. And we estimate that maybe over 100 million people with diabetes here in India. If you look at 25% of people who will develop a foot problem, we are looking at 25 million people with foot problems here in India itself. Somebody once said, if diabetes was a country, it'd be the 5th biggest country in the world. And what we have seen, and I've discussed with Ghanshyam, is a number of amputations we are seeing and the mortality in people with diabetic foot problems, which is equivalent to some of the common cancers that we see in the world today. So why is it that we're not giving the same funding and the same drive to reduce problems when people with diabetic foot reduce amputations like we do for cancer? That is something we need to take up with the authorities and with government. Because especially here in India, we are seeing greater number of people with foot ulcers and also amputations when you compare it to the West. The data on the top, as you can see, is in the UK. This is per 100 people with diabetes, and you can see the number of amputations occurring in the UK when compared to India. So there is definitely greater number of ulcerations and amputation occurring in India, and that could be for various reasons. You know, in India, we have people living out in villages, remote places where they don't get foot care. I was privileged yesterday to go with Indrajit and Dr. Mujumdar to the island of Bali in the Sundarbans, and we saw that people there with diabetes, how many of them had neuropathy, some had peripheral arterial disease, who didn't know they had the condition, and we identified patients who had neuropathy and PAD. So these are the people we need to be targeting. So what we have written for the IDF is a clinical practice for the diabetic foot. And this was by, unfortunately he's now passed away, with the past president of the IDF. He was from Mumbai, and he asked us to this Professor Sadikot, he asked us to write these guidelines, which we wrote for the IDF, which is very simple guidelines. We didn't write something that was too sophisticated, too scientific, because we wanted it for lay persons, but also for doctors at the grassroots levels who can access these guidelines to give proper care for diabetic foot. So what we did is we divided it into neuropathy, PAD, foot ulcerations, foot infections, and also Charcot foot. And this is available online. It's available to download for free. You can access this online, and it was done in 2017. So this is what we discussed yesterday following the meeting that we had and the boat trip we had to the Sundarbans. We need a diabetic foot week. We've got nutrition week, we've got the AIDS week, and other weeks for other disease conditions to raise awareness. Why don't we have a diabetes foot week? So what we want to do now is have a national diabetes foot week. We've chosen this date so it falls just after the World Diabetes Day, so the awareness that is being raised on International World Diabetes Day, we continue with the diabetic foot week. And what we want to do is to increase the awareness on diabetic foot, to improve care for people with diabetes, to improve screening and to improve the treatment. So hopefully we can reduce ulcerations and also reduce amputations. So what we need to do therefore is do regular foot checks on patients, at least on a yearly basis, but also for patients themselves to check their feet every day. When I see a patient in my clinic, I see them for 20 minutes, but the rest of the year, they have to look after their feet themselves. So we want patients to know, to identify when they have a problem, when they need to come to see the podiatrist, the foot specialist, or the consultant. And that's why we need to educate patients, and that we can do through various means. Could be to television, newspapers, WhatsApp messages, etc. There are so many ways by which we can raise the awareness. This is something that Professor Sadikot wanted to do. Unfortunately, this could not be done. So obviously, as in anything in medicine, it always starts with inspection. You know, you have to first look at the patient, and you can find out by looking at the patient a lot of problems the patient may be having. The same thing also with the foot. When I used to work with a professor in Manchester, the first thing he said was, the foot examination starts when the patient's walking through the door. The moment he puts his foot into your clinic room, you start the assessment. How he walks, is he walking with a limp? You know, is he having problems with his feet? You can do that just by looking at him. So what we need to do is inspect the foot, and inspection of the foot, we're looking for various deformities. I won't go through all the details because Rekha will be covering this also later on. But really we're looking at, are there any foot deformities? Because when people have got foot deformities, it increases their risk for foot ulceration. Some of these deformities can be accommodated in proper footwear. Some of these deformities can be corrected surgically. And we have got devices available to us, we've got specialists available to us who can correct some of these deformities. And therefore, by improving these deformities or by reversing these deformities, we can reduce the risk for ulceration in people with diabetes. Also a lot of callus formation, that is something else we need to look at, and Rekha's got an excellent patient with us today, and she's going to demonstrate what is callus and how the callus should be removed so that we can reduce the risk for ulceration in people with diabetic neuropathy. So just quickly to go through it, foot examination, we need to look for muscle wasting, we need to look for any foot drops or prominent metatarsal heads, because this is where when people walk, increased pressure under especially the first metatarsal head, but could also occur on under the other 4 metatarsal heads, but this can then lead to increased foot pressures. If they've got claw toes or hammer toes, again that can lead to pressures either on the top of the toe or on the tips of the toes, and this again can lead to increased pressure and ulcerations. Then we got bony prominences like bunions, etc. Again, these can be corrected and we can reduce ulceration. Now this patient, because of wearing improper footwear, can develop an ulcer on this part of the foot that can get infected, they can get osteomyelitis, and then this can lead to amputations. Prominent metatarsal heads, I mentioned earlier, this is because of neuropathy. Again, this can lead to ulcerations under the bottom of the foot, on the plantar surface of the foot. And of course, the most important complication is Charcot neuroarthropathy, occurs in people with diabetes, poorly controlled diabetes with neuropathy. It can lead to destruction in the bones in the feet, leading to severe foot deformities and rocker bottom deformity. And this can lead to, again, ulceration, infections, and risk for amputations. Again, this is preventable, or if picked up earlier by giving the right treatment, we can reduce the risk for people from developing severe deformities. This is something we don't always do in clinic, but this is a nice way of looking for limited joint mobility. If you put your hands together, you should not have any space between your hands. That shows that your joints are quite malleable and there's no limitations in the movement of the joints. But people with diabetes, with neuropathy, because of glycation of the ligaments in the joints, they get limited joint mobility, and then when they put the hands together, you can see this space between the hands. Obviously, you can't put your feet together, but by putting the hands together like this, you know that the patient also has got limited joint mobility in his feet. And because of this limited joint mobility in the feet, again will lead to increased pressure in the foot, leading to risk for ulceration. So, diagnosis of neuropathy, Rekha's got some tools. We'll be looking at how to diagnose neuropathy, but we have got multiple tools available to us. But the most common one that we use is the light touch, using the 10-gram monofilament. It's important to do the screening properly. It's important that we do it in the right manner, so we don't overdiagnose, but also we don't underdiagnose the condition. And I always tell people, when you are checking for neuropathy, you must, when you're doing the test, the only sensation you give to the foot is with the device that you are using. In other words, you must not be holding the foot and also applying the monofilament. Because if you're holding the toe and applying the monofilament, the patient can confuse the touch you're giving with your fingers to the monofilament. So remember, when you're applying the monofilament, it's only the monofilament that must be touching your foot. Nothing else should be touching the foot. You must not be holding the foot, or your clothes or something else should not be touching the foot. So the patient does not get confused with the sensation you're applying to the foot. When I've seen people doing this test, sometimes they hold the toe and they're applying pressure there. So the patient does not get the right sensation. Okay, so the important thing is, it's just the monofilament that must be touching the foot. You can then do vibration perception using a 128 Hz tuning fork. This applied to the tip of the toes. Some people apply to the bony prominence on the big toe. You can do it either way. And then, of course, there are other tests we can use. Remember that light touch and vibration assesses the large fibers. The first sensation to go in somebody with diabetes is large fiber. So they have large fiber neuropathy. In about 10 to 15% of people, they can only have small fiber neuropathy, which means we need to do pain and temperature. Because if you don't do pain and temperature, you could lose that 15% people who have normal large fiber sensation. So I think we should be also testing for small fiber sensation. Again, we can use a neurothesiometer or a biothesiometer, but remember this device is expensive, we require electricity. As we saw yesterday when we went on the boat trip, it was very hard for us to get electricity. So sometime when you go out in the villages and remote places, they may not have electricity. So I think what we need is a monofilament, which is cheap, easy to use. Vibration perception, again, durable device, or using devices to check for small fiber neuropathy. One thing you need to know is that if you're using the monofilament in too many patients, you can lose the elasticity of the monofilament, which means what is 10 grams can become 9, 8, and then 6 grams. So you might overdiagnose neuropathy in some people. So studies have been done showing that if you got 20 patients in clinic, you must have 2 monofilaments. Okay? Use 1 monofilament for 10 patients, then let it rest for 24 hours so you get the monofilament gets back its elasticity. Please do not use it for more than 10 patients. Okay? So if you've got 30 patients, have 3 monofilaments, etc. Okay? So 10 patients for each monofilament, and then you must rest it for 24 hours. Of course, then we got what we call this peripheral arterial disease. You know this condition. It's important to diagnose this because many people nowadays, because we got, at least in the UK, we got a lot of elderly patients because people are living longer, 75, 80. And these patients are now developing peripheral arterial disease, blocked arteries going into the legs, and they get ischemic ulcers. So we're seeing more patients now with neuroischemic and ischemic ulcers than neuropathic ulcers in the UK. Because we got such good foot preventive care in the UK, we are not seeing that many patients with neuropathic ulcers. We are seeing more patients with neuroischemic and ischemic ulcers. I know in India it's just the opposite. We see more neuropathic ulcers and fewer people with ischemic ulcers. So how do we assess for peripheral arterial disease? You need to check the pulses. Check the pulses, dorsalis pedis and postiotibial. The dorsalis pedis is present on the dorsum of the foot, and the postiotibial is present behind the medial malleolus. It's very easy to palpate. All it needs is a bit of practice. Sometimes the dorsalis pedis at least can be absent because the patient was born without an artery. Okay? But the postiotibial is always present. The postiotibial is always present. And they need just one artery to perfuse the foot. So if they have absent both pulses, then there's a problem. Usually, if they have one good pulse, that should be enough to perfuse the foot. So examine the pulses. If you can't feel the pulse, then you do what we call is the ankle brachial pressure index, or ABPI. The ABPI tells us what the pressure is and what the circulation is doing in the lower limbs. So for that, we check the pressure in the brachial artery, okay, on the arm, and then we check the pressures in the dorsalis pedis and the postiotibial. It's easily done using a Doppler machine. You then divide the ankle with the brachial pressure. Normal is 1. Anything less than 0.9, the patient has got peripheral arterial disease. Anything less than 0.9. If it's below 0.5, the patient has got critical limb ischemia. Critical limb ischemia. So obviously, we don't want patients to go down to develop critical limb ischemia. And how can we avoid that from happening? Good diabetes control, good blood pressure control, giving the patients statins, anti-lipid therapy, and aspirin. Okay? These drugs are not that expensive nowadays, but when we did the clinic yesterday, we had people with poorly controlled diabetes. Some of them had PAD, some of them had chondroitic disease, and some of these patients did not have any aspirin in their list of medications. They were on statins, but they were not on aspirin. So again, this is something that we need to be pushing. We've just published a paper where we have shown that in the UK, people with diabetic foot actually had better control of the cholesterol than people without foot problems. So one of the queries was, why is it people with foot problems have got better cholesterol? And I think that is because we are driving patients with foot problems the cholesterol down. Because they come to my clinic every week, I send them every month, so we are checking cholesterol, we're checking their blood pressure, and we are treating those things. Whereas people without foot problems, they're seeing the doctor maybe every 6 months or every year. So they may not get the same intensive treatment that we're giving for people with diabetic foot problems. So actually, we are doing good for these patients, but I think it's coming too late. We should be doing this before they develop these problems. So anybody with diabetes, cholesterol, blood pressure control is very important. So we can prevent people from going to developing severe PAD, or what we call critical limb ischemia. So those are the pulses we would feel. So what we do here in the UK, this is something we do in our clinic. Different people have different ways they would do it. But what we recommend in the UK is to do what we call is an annual diabetic foot screen. So at least once a year, these patients should be having a complete foot assessment done. So we look for signs, we look for symptoms, we do some tests, I'll talk to you in a minute, and we look for other factors. So by signs, we look for any ulceration that may be present, we look for any foot deformities, like I mentioned earlier, any other foot pathology, and footwear. We always check the patient's footwear when they come to clinic. And what we have always been taught, and what we always tell our patients, if somebody comes to clinic with an ulcer, and the patient is wearing footwear that we think is inappropriate, the patient should not go home with that shoe on. We should give them something in the clinic, like a sandal. We call it Darko sandal, but there are other things that we have here in India. The patient should go home with something that is more comfortable and not cause more problems. We then ask for any symptoms like claudication, any rest pain, tingling, numbness in the feet, symptoms of painful neuropathy, and we ask for any history of ulceration. Of course, in the test, like I said earlier, we check the pulse, we check the foot temperature, because they could have underlying Charcot or infection, so it's important to check the temperature, and then using the monofilament and the sharp and blunt. So monofilament, large fiber, sharp and blunt would be small fiber. At least these two tests should be done, and those have been put in many guidelines that you must check at least one test for large fiber and at least one test for the small fiber. And then other factors that are important, and we did a big study in Europe called the Eurodial study, and we looked at all the risk factors for why people can get an ulcer. And these are just some of the ones that we have picked up from our study in over 1,200 patients. We need to watch how long they've had diabetes for, what's their glycemic control, so definitely an HbA1c at least twice a year, if not more frequently. Do they smoke? What about their eyesight? Do they live alone? We found that people who live alone had a greater risk for ulceration, but also amputation. Why? Because then they can't come to the clinic as required. Okay, so it's important to know, are people living alone? Can they look after their feet? And what about their knowledge about foot care? Something that's very important is educating patients. In the UK, we have a program called Location, 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 where they talk about, where to go and buy a house and what's the best place to buy a house. So we say education, 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 okay? So that is so important to improve the patient's knowledge. So when they come to clinic, they're spending half an hour with you, with the podiatrist, talk about feet, talk about diabetes, talk about aspirin, talk about cholesterol, We talk about everything. We talk about their family, we talk about their dog and their cat. Okay, I think it's also important to talk about, what knowledge they've got, because it's important to reinforce. The moment the patient goes home, he forgets 90% of the thing you've told him. But if he comes to you on a weekly basis or a monthly basis and you keep talking about the same thing again and again, he will remember more and more. Okay, so it's important that we keep talking about that. We then risk categorize these patients. So the high risk patients, we put the color red because they're the ones who are the ones with most problems. Have they got neuropathy? Have they got PAD? Have they had previous ulcerations? And have they had an amputation? It is this group of patients that are at very high risk for future ulcerations, but also amputations. People with moderate risk are those with reduced sensation or mild PAD, and then low risk are those who got good sensation, good pulses, and no previous foot problems. So if somebody's got callus under their foot, these people go straight into the moderate category, because that, if they keep walking that callus, they then develop micro hemorrhages or small bleeding under the callus. This can then break down to form an ulcer. So moment somebody has callus, it means they've got neuropathy or they've got a foot deformity, and that callus can break down to form an ulcer. So that straight away puts them into the moderate risk category. We then give patients foot leaflets, and I'm sure you've got leaflets here that you give your patients. It's good to give it in the local language, which will definitely help. But I think we need to educate the patients by giving them leaflets, because they can take that home, they can read at their leisure, and that will reinforce the education that you have given them. And then we do referrals to this patient depending on when to refer patient. That is most important. We did a few studies in the UK where we found that patients are being referred very late to the clinic. The study we did in Europe, there were some patients who were referred 3 months later to the foot clinic after developing an ulcer. The same with Charcot neuroarthropathy, patients were being referred 3 to 9 months late after they had reported to the healthcare, to the general practitioner that they had a problem with the foot. So it's important, and this is what you're doing in Tameside. Once a year we're doing training programs now for GPs and other healthcare professionals, so that people are referred in a timely fashion. So foot ulcers can be neuropathic, they can be ischemic, or they can be neuroischemic. So neuropathic ulcers occur in somebody who's got neuropathy, neuroischemia in somebody who's got neuropathy plus ischemia, or ischemic ulcers, somebody who's got good sensation but only poor circulation. Ischemic ulcers per se are not that common. About 10% of the population will have that. More importantly, at least in the UK, we see more neuroischemic ulcers. Again, the Eurodial study, 54% of people, so over half of the patients had neuroischemic ulcers. Less than half had neuropathic ulcers. But data coming from India, people mainly have neuropathic ulcers, and this is not that common. And I'm sure Ghanshyam will agree with that. So neuropathic ulcers tend to occur on the plantar surface of the foot, usually under the first, the big toe or the first metatarsal head, because when you walk, you put most of your pressure on your first metatarsal head, okay, or your big toe. That is why people get maximum ulcerations on that part of the foot. If you look at the ischemic ulcers, they tend to occur on the tips of the toes, because that's where the circulation is affected the most, or they have microcirculatory problems, so it tends to occur commonly on the tips of the toes. Whereas neuroischemic ulcers tend to occur more on the lateral surface of the foot, usually because of ill-fitting footwear. Okay, so it's important to be able to differentiate the different types of ulcers, so you can give the right treatment or initiate the right treatment. Foot deformities, we covered that again. So you got the different deformities. We need to be able to identify what type of deformity the patient has got, so you can make the right diagnosis, refer the patient to the orthopedic surgeon necessary to try and do some correction of these deformities. So managing foot ulcers, again, the mainstay of treatment is not applying expensive treatments, expensive creams, or using expensive devices. The most simplest of treatments, and Rekha will show you later on, is wound debridement. Okay, debridement, taking off the callus. I used to work with a podiatrist from Australia, and she said it's not what you put on the wound that is important, it's what you take off the wound that is important. Taking off the callus, taking off the slough, taking off the pressure. So good wound debridement will reduce the pressure around the ulcer. It will also help the wound to heal. Okay? Because when somebody's got callus, what happens when somebody's got callus? So the callus is like a foreign body on the foot. So for the wound to heal, which is here, and you got the callus, normal skin from the side of the foot cannot grow into the wound to close the wound, because the callus is preventing that from happening. But if you take out the callus, then the normal skin can grow across, and you can then close the wound. So good wound debridement is the mainstay in treating the diabetic foot. Of course, then taking off pressure will prevent the callus from recurring, and then using the right treatments such as dressings, treating infection, and the circulation is important. Obviously, infection is an important risk factor for poor healing, but also amputation. So we need to be able to identify when somebody has got an infected foot ulcer. Again, the study we did in Europe, over half of the patients who came to our foot clinics the wound is already infected. So if we can't identify a wound that is infected or underlying osteomyelitis, then it might be difficult for that wound to heal. And when we don't treat infection properly, that infection can go deeper into the foot, it can affect the bones, so they get osteomyelitis, and then lead to an amputation. So again, having the right tools to diagnose infection is also very important. So wound debridement, easily done if you are trained to do it, okay, and it's not that difficult to do, and it's easy to train people to do wound debridement. In the UK, we got excellent podiatrists who help us with the wound debridement. In India also, we got good podiatrists, we got good nurses who are doing it. But it's important that it is done properly, because sometimes not doing proper debridement can also lead to problems. And of course, offloading, and again Rekha will show you some of the offloading devices that are used here in India. In the UK, we use the total contact cast or the air cast, and of course these are the sandals we would use for patients who cannot use a cast or who don't want to go into a cast. Obviously the cast is the gold standard. A lot of studies have been done showing that using a total contact cast will improve wound healing, okay, and also reduce risk for amputations. There are a lot of dressings that are available to us. Remember, dressings are expensive. You don't have to use the most expensive dressings, because the evidence behind dressings is not as strong as the evidence behind debridement and offloading. So using expensive dressings will not always make the wound heal faster. Okay, so you need to use the right dressing at the right time, and for that you need to have some knowledge on how these dressings work. So we can classify foot ulcers in various ways. This is the Wagner classification of foot ulcers, and it is good to know how to classify foot ulcers, because you are trying to discuss a problem with a colleague or with the diabetologist or with the surgeons. It's good to tell what type of ulcer a patient has got. So the Wagner classification goes from grade 0 to grade 5, and it tells you if the patient has got neuropathic ulcer, that is superficial, not infected, if it is infected with bony involvement, or if there's gangrene involving part of the foot or the whole foot. Okay, so that will help us saying, oh, this patient got a grade 5 diabetic foot, which means he's got a whole foot gangrene. This is an emergency, and these patients need to be in the accident emergency department or casualty, so that patient can be managed in the right manner. Or we've got the University of Texas wound classification system. Again, this is slightly complicated, but once you use it frequently, it's then easy to understand. So you got the staging from 0 to 3, and the grades A, B, and C. And then it depends on whether the wound is infected, ischemic, or there's infection and ischemia. So if somebody's got a wound which is, say, A1, 1B wound, then this is a superficial wound which is infected. If they got a 2B, it is penetrating into bone and it is infected. If it is 3D, there's infection and also ischemia. So what we have done when we did a study, if you go across the grades and the stages, that somebody has got a wound that is right down there, this is the one that is most high risk for amputation. So what we would like to see is somebody with, if they got an ulcer, that is something that is somewhere up here, because this is easily manageable. Somebody with a mildly infected wound, it is much more easier to treat that wound and prevent an amputation. Okay, and we showed this again in the Eurodial study. 90% of neuropathic superficial ulcers that are infected, we can prevent an amputation in those patients. So how do we detect infection? Simple, okay, is there redness, is there warmth, is there swelling, induration, and pain. These are the 5 hallmarks of infection. If they got 2 or more of these, then they have got an infected wound. Remember, not all ulcers are infected. There's a tendency in some clinics that anybody with a foot ulcer must have antibiotics. Antibiotics do not heal wound if there is no infection. So please do not advise antibiotics if the wound is not infected. 1, you're causing antibiotic resistance. 2, you can cause Clostridium difficile. which you know is a quite a severe complication of antibiotics. So antibiotics should be used only if somebody has got an infection. So this is a patient who came to our clinic, and you can see the patient has got quite extensive cellulitis. Okay, remember that if somebody's got intact skin, they should not get cellulitis. They should not get a wound infection. So this patient was trying to cut their toe. Okay, this has moved slightly. It's actually there, if you can see it. They were trying to cut their toenail, and by mistake this patient nicked the skin also. Okay, the moment the skin gets cut, then that loses the barrier for infection. Okay, and then she developed severe cellulitis. Okay, so somebody who's got cellulitis, we should be treating these patients aggressively, because again, when they've got infection, there's a risk for amputation. This is another patient. This patient came to hospital, had fractured the hip, and this patient was lying in bed for a month and developed an ulcer on the other foot. Okay, in the UK, we call this a never event. Nobody in hospital should get an ulcer, whether it's on the heel, anywhere else on the foot, on the back, on the buttocks, wherever, because we should be taking good care of pressure areas. And in people with diabetes, this is not uncommon. Okay, this can happen in people with diabetes because they're lying in bed on their heels, and what they do when they lie in bed, they're trying to push themselves up, so they use their heels, causing friction, and then the skin starts to break down. And this is exactly what this patient did. And you can see now that the patient has got quite a lot of necrosis and infection. So this is something that should never happen in any patient, but definitely not in hospitals. And if this happens, we get reported to the health authorities. Okay. So infection of the diabetic foot, it can be mild, moderate, or severe. The most common organism causing infection is Staphylococcus aureus. We have shown this in our clinic, but in places like India, where people walk bare feet, it can be polymicrobial. So they can have gram-negative, they can have anaerobes, but also gram-positive infection. So again, knowing what type of organism is causing the infection, we can then use the right antibiotic. So this is the patient who came to our clinic. He had this ulcer for about 2 months. He was being treated locally in a local practice, and then referred to the foot clinic. Do you think this wound is infected? Do you think this wound is infected? It doesn't look, no? It doesn't. It looks very clean. There's a bit of callus, okay, because he's not had much debridement. He was being seen by the local podiatrist, but it doesn't look like it's infected. There's slightly what we call hypergranulation, okay. So what would you advise for this patient? What would you advise? Definitely offloading, yeah, offloading, wound debridement, to try and take away the callus, okay, but you would do an X-ray. Anybody who's got an ulcer that is there for more than 4 weeks, or if the wound is probing to bone, remember in this case the wound wasn't probing to bone, okay, you can't see the bone, you can see nice tissue around on the ulcer, but we took an X-ray on this foot, and we showed that the patient had osteomyelitis. Okay, so anybody who's got a wound that is present for more than 4 weeks, it is important that we do an X-ray, because you can pick up underlying osteomyelitis. So osteomyelitis is so important to diagnose, because again, increase the risk for amputation. The first thing we do in any foot ulcer, and I'm sure Rekha does the same thing, is we probe the wound. We probe the wound with a metal probe, and if we are hitting bone at the base of the ulcer, that means that person has got an 85% chance of having osteomyelitis, and then we would do an X-ray to confirm the diagnosis. So 85% chance that this person will have underlying osteomyelitis. So if we hit bone at the base of the ulcer, we should be doing an X-ray. If the X-ray is normal, which can happen because X-ray is not very sensitive in picking up osteomyelitis, we would then want to do a MRI scan. Okay, we do an MRI scan that has got a 90% sensitivity and specificity. An X-ray has got a 50% sensitivity and specificity. Why? Because for an X-ray to pick up osteomyelitis, 50% of the bone needs to be damaged. So if you can't do an MRI scan because it's expensive, it's not available, it's good to repeat the X-ray in 2 weeks. So that's what we would do. If people can't do an X-ray, we would repeat the X-ray in 2 weeks, and it will show then if there's underlying osteomyelitis. I won't go through this because this is just basically telling you how to treat infection and what antibiotics to use. The most common ones we would use is flucloxacillin. If people can't take penicillins, we would use clindamycin and ciprofloxacin. So again, picking up infections at the earlier stages is probably best, because when you go down to the most severe stages of infection, the patient would need to be admitted to hospital and IV antibiotics, and that would make it more expensive, okay, and of course inconvenient for the patient. So I think it's important that we pick up patients with infection much earlier on. And again, people like yourself, when you go out in the community, you are the ones who are ideal to pick it up. Dr. Goyal will see patients who have more serious conditions, not the people with mild infections. So we need people like yourselves going out there, identifying patients with mild infections, advising antibiotics either from their local doctors or taking advice from Rekha or Dr. Goyal. So I'm going to stop there because Charcot-Foot maybe is going in more in depth, and I'll let Rekha now take over. Thank you.
Thank you, Ed, for excellent talk as usual, and you have discussed in detail regarding the prevention of diabetic foot. Very important. How you will screen the diabetic foot? It is the annual screening program. It's a low risk, medium risk or high risk. He have shown it that if you have got a neuropathy, loss of protective sensation, then you are at high risk. If you have got deformities or callus, then you are moderate risk. If you are having a history of amputation, peripheral vascular disease, or you are having Charcot-Foot, you are at very high risk category. And then how to classify the ulcers, neuropathic ulcers, ischemic ulcers or neuroischemic ulcers. And he have rightly mentioned to treat a ischemic ulcer is more costly. It's very costly to treat the ischemic ulcers because it may lead a angioplasty of the feet or of the foot, or you may require the bypass of the feet or foot, just like coronary artery bypass and other things. So it's a very costly affair, and it has been mentioned by Ed that the treatment, cost of treatment of diabetic foot is more than 5 most common cancers, and even the survival is less than 5 most common cancers. So thank you very much. Give a big hand to Ed for giving such a nice talk and total overview of the diabetic foot and how to examine. And you doesn't require very sophisticated gadgets. Just you will have a pair of hands and eyes, and by that you can detect who is at high risk. But just having a look on the ulcer, you can have it. So now they are starting with the just workshop. We have got 2 patients. Sir, can you please say your name, sir?
My name is Ramesh Karera.
So give a big hand to Ramesh ji for coming and taking all the pains to coming here. So his कब से इनका हिस्ट्री एक बार दिखा दें. आपको कब से डायबिटीज है रमेश जी? He is a diabetic since last 25 years. Hey, এটা চালাও তো.
Pointer and slide change.
आपको रमेश जी पैर में ये प्रॉब्लम कब से है? So he is in problem in the feet since 7-8 months. So क्या प्रॉब्लम क्या था सर आपको?
खाली खून निकला था यहाँ पे.
कैसे हुआ था?
अपने आप हो गया, पता नहीं मेरे को कैसे हो गया.
So he doesn't know how it happens. So probably he is in loss of protective sensation.
Please
Probably
slide
because he is not
slide.
knowing why it happened.
Slide.
So तू वो
Slide.
स्लाइड का पहले
Yes.
हिस्ट्री दिखा ना.
हाँ दिखा रहा हूँ. Slide স্লাইডটা চেঞ্জ করো।
স্লাইডটা চেঞ্জ করে একটু হিস্ট্রি স্লাইড আছে না, ওটা দেখিয়ে দাও, তারপরে দেখা যায় কি কি করতে হবে।
So he is 63 years in my camera. My head.
No.
So he's basically a businessman and he is coming from his work. So thank you, Mr. Karira. And he is 25 years, diabetes 25 years, and he is also a diabetic patient. He is on oral medication with insulin, and he is also taking the anti-diabetic and antihypertensive medication. So.
So
So
just बस बंद कर दो, ये जस्ट बंद करो, এটা বন্ধ করে দাও এখন, তুমি এর মধ্যে ফোকাস করো, তুমি ফুট এক্সামিনেশন দেখাও ऊपर से dorsum and plantar surface, then palpate the pulses and see the flow
will
and
first
see the
see
monofilament
how
test
to
and everything.
how to examine the foot. So you can see first look the texture of the skin and temperature. You can see of the both foot.
Always examine the both
Temperature.
feet, not
Okay.
only the one
And
feet where the problem is. So always remember, it should be, you have to examine the patient's both feet. If patient is complaining only, and one thing here I want to say, I always say whenever we discuss, start your examination in diabetic from foot to head, not from head to foot. So it is apadamastak in Sanskrit. So always examine your patient of diabetes from feet to head, so you are not going to miss the diabetic foot.
So you can see first we inspect the foot. You can see there is a big callus at the fifth empty head, and you can also inspect in between the toes, because in Kolkata and West Bengal, and there is a very high humidity, and patient may have this some
Interdigital mycosis is very common
mycosis.
in
So
our
in
country.
this patient you can see the toes are all there is no interdigital mycosis. And about the deformity, you can see there is no deformity, but there is nails are thick. If you can see, the nails are thick, and in this foot some nails are growing inside. So there is a ingrowing toenail, and you can see
Due to
these
neuropathy, the nails are very thick and it's difficult to.
Also, what you can see, because of neuropathy, he's got dropped plantar arches. So he's got problem in the metatarsal head. He's
Yeah.
got pes cavus, and also the foot is rotated laterally. I remember I told you earlier, people normally get ulcers on the first metatarsal head, but because of neuropathy, his foot is moved laterally, which is why he's got ulcers on the fifth metatarsal head.
Yeah. And in palpation, as sir has said in his presentation, we have to see the dorsalis pedis. If you see, there it is palpable. We will see also in the ankle brachial index. So this is
Always look for the both,
dorsal
palpate
pedis
the both pedal
and
pulses,
dorsalis
dorsal
pedis
pedis and tibialis posterior.
and the posterior tibialis.
And one thing
Yeah.
very important I
It is
just want to mention
behind
here.
the lateral malleolus, medial malleolus, just behind the medial malleolus. You can always palpate in both feet.
One thing here I just want to mention, if the pulses are palpable, means it's okay. If it's bounding, it's neuropathic. It's feeble or absent, means ischemic, means the flow is compromised. So just by putting your fingers on the pulses, tibialis posterior or dorsalis pedis, you can identify it's a normal, it's a neuropathic, or it's a ischemic by just putting your fingers on the pulses. So it's a feeble or absent, it's normal, or it's bounding. In neuropathy, it will be bounding. So these are very simple tips you can.
So for the neuropathy test, yeah, for the neuropathy test, we will do the monofilament. This is the 10-gram monofilament. So how do we perform
What
this test?
Professor Jude have shown, how you will test the monofilament test. It is a loss of protective sensation to detect that.
So first we have to ask the patient in
सुनिए, आपको क्या कर रहे हैं?
एक ये लगा रहे हैं, आपको फीलिंग हो रहा है?
आपको फील हो रहा है ना, तो अगर आपको फील हो तो बोलिएगा, और आपको फील नहीं हो तो मत बोलिएगा। बल पैर में करेंगे, जैसे हाथ में आपको फील हुआ ना, तो फिर बाद में आप या तो हाथ, अगर आपको फील हो तो हाथ उठाइएगा, और आपको फील नहीं हो तो हाथ नीचे रखिएगा, ठीक है?
इसी तरह का सेंसेशन अगर आपको पैर में फीलिंग होगा तो आप बोलिएगा। जस्ट क्लोज योर आईज।
देखिए, and remember it now, the area which has to be tested by 10 milligram monofilament is the great toe, first empty head and fifth empty head. Out of these three areas, if you are able, a patient is not feeling at two areas, then patient is lots of protective sensation is there. So just she is going to demonstrate you.
See, and
Yeah.
you have to give the pressure so that the monofilament is had to buckle. And you have to put the pressure for 2 seconds. And the ulcer or callus area, you don't need to check at this area. So I'm again doing in this foot.
ठीक है?
And one SAM test is definitely do.
अब
But I'm not putting.
सुनिए, आपको टच नहीं किया है अभी, तो आप में बोल रहे हैं कि महसूस नहीं, अभी रुकिए, अब देखिए, 1 मिनट रुकिए, अब बताइए।
No.
ठीक है, कोई बात, इट्स रियली समटाइम्स कंफ्यूजन सो मे हैपन। अब पता चल रहा है कि देखिए तो अब नहीं, he can't, he is unable to.
So that means he is neuropathic.
One thing I tell you, if there is a callus, it means he is in loss of protective sensation is there. That's why he got the callus, and he knows, he already mentioned in the history, he doesn't know how it happened. So it means neuropathy is already there.
And by monofilament, we are able to know that patient is neuropathic. But to quantify, so we have to do the vibration perception threshold. So this is the machine.
VPT.
Okay. So similar way, we have to show in his hand. करीरा जी, आपके हाथ में हम लोग थोड़ा सा एक ये टेस्ट कर रहे हैं।
लगे तो आप बोलिएगा, कब आप लगा के
कुछ सेंसेशन हो रहा है? कैसा सेंसेशन हो रहा है? थोड़ा सा वाइब्रेशन हो रहा है ना? ऐसा ही वाइब्रेशन,
कितने पे हुआ?
ये तो बहुत ज्यादा दे रहा है हाथ में। ऐसा ही वाइब्रेशन बंद कर दे। करीरा जी, आप ऐसा ही वाइब्रेशन आपके पैर में हम लोग देंगे।
If the VPT is more than 25, at that level he feels, it means it's impaired. Okay, so that is there. So वो देखिए आप, and the same sites, great toe, first empty head and fifth empty head, you have to check.
तो करीरा जी, आप आंख बंद कर लीजिए एक बार।
और जब आपको लगने लगे तब बताइएगा, हाँ मेरे को लग रहा है।
So you can see in 50, he is not able to sensate.
Tense neuropathy. He is in
tense
loss of
neuropathy.
protective sensation, so he is in neuropathy. And it is on high pressure areas, it is on the fifth empty head, so it suggests it's neuropathic, it's not ischemic. एक बार ये भी दिखा दे वाला, वो हैंडल डॉपलर से दिखा दे, ठीक है?
So you can see till 50 he is not able to perceive.
अभी ठीक है, कोई बात।
And in the similar way you can test on the on contralateral foot.
In the both feet you have to examine, always
So
remember.
we have see the patient is neuropathy. Now we have to see the vascular status. So first we have to check the pedal pulses. So it is there. Now give some jelly and
It's a triphasic sound which is coming, so it's a yes neuropathic and bounding rather. The sounds are very much and check it on the tibialis posterior also. यहाँ पे भी देख लो, यहाँ पे भी, put it here. flow is adequate, so it's a purely neuropathic foot, okay? And we know that there is a LOPS, loss of particular sensation, or large fiber neuropathy is there. And there is a callus on the 5th empty head area. So now she will show you. Yeah,
Yeah.
yeah, of course. We have to check the both the feet. Always, whenever a patient comes, and I, at the initial remarks, I told that if patient complains in one foot, always examine both feet and then only proceed. So, and now she
slide,
will
please.
show you, as Dr. Jude have shown, why callus is important and why to remove the callus. And one thing I'll just mention, just like Apadamastak, never be callous for the callus. Always remove it, because it causes high pressure areas, and that lead to, as you have shown, hemorrhage inside the callus and then the formation of ulcer. It's a pre-ulcerative pathology. And there might be hemorrhage inside the callus. So it's, now she's going to show you how to do
First,
that.
I have to show you at a presentation what he is complaining. Please, please show the slide. इसमें जो उनका ना abscess था, मतलब वो जो abscess था, yes.
Case number 2 दिखाओ तो. What was there? There was an abscess inside this callus. So
Sir, as you mentioned, there is a high pressure area due to callus, and there is a hemorrhage inside the callus, and following that abscess formation.
फर्स्ट टाइम कब आए थे आप दिखाने? 6-7 महीना पहले. उसके बाद अभी परसों आए थे आप? 2-3 बार आए थे. अच्छा, ठीक.
Yeah.
या. केस नंबर 2 दिखा दो उसमें.
Yeah. When he came to us, you can see there is a callus, and with the callus there is a formation of abscess. Yeah. There is a formation of abscess. Yeah, this one. Yeah, there is a abscess. So after that we debride it.
Next slide.
नहीं, यहाँ से change नहीं हो रहा है.
नहीं, वहां से कर देगा. You can change.
Yeah. After debridement, this was the ulcer condition, and we give him this type of offloading. This is our indigenous technique of offloading. We give this type of offloading, and after this, next slide. And and after 5-week follow-up, this is the condition.
This is the
condition after 5 weeks.
We take the foam, roll it, wrap in a piece
And
of
after
gauze
7
gauze,
weeks,
and
and
just stick with the
at 11 weeks, the ulcer is completely in remission. Now,
again he had a
Again,
recurrence. So always use the term, never use the term your ulcer is healed. Always use the term ulcer is in remission. This is a better term. So patient will take care of their ulcer. If you say healed, আপনি তো বলেছিলেন আমার আলসারটা ভালো হয়ে গেছে, এখন আমি কেন খেয়াল করব? তো always see that you are having very high chance of recurrence, and 1 year rate of recurrence is more than around 40% in 1 year. So it's 40%, in 3 years 60%, and in 5 years 75%, more than 75%. So always say that your ulcer is in recurrence, never say it's healed, remission. So now she's going to show you, as he had recurrence, he was in remission for at least 3-4 months, but again he had recurrence. So now she is removing the callus. You should look into it,
for
and
the
it's very simple.
debridement, we are using number 15 blade, and this is the blade handle, and now we can remove.
Hey, chairটা একটু পাশে করে দে ম্যাডাম। জয় ওর পাশ में push 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 push.
As it is neuropathic, so we can remove safely. So always during removing, you try to remove in small pieces. So always try to remove in small pieces. from the upward to downward.
And try to remove in pieces, not in one single piece. Always remember it. Small pieces.
It is very hard, and you can see there is a
Sometimes
hemorrhage.
we require the nail nibbler to remove it. It's so hard. So remember it.
And you can see there is a hemorrhage inside this callus. I am just removing this. Just
সবাই
wait.
এসে জিজ্ঞেস করে ডাক্তার লাগবে না তো আপনি এটা কাটছে লাগবে না তো অ্যাকচুয়াল
see
পেশেন্ট
there
ইজ
is a
অলরেডি
hemorrhage.
নিউরোপ্যাথি সো হি ইজ নট গোইং টু হ্যাভ এনি পেন এট অল
The color difference because of the hemorrhage.
Yeah.
Can you see the black color? So he's bled into the into the callus.
So we always advise the patient, whenever there is a hardness, you just come to us, we will remove. Otherwise, it will get infected, and there is a lot of hemorrhage and maybe pus. You can see.
You see? So there is
Yes,
a
there is
ulcer. You see, there is a ulcer inside the callus. So there is a hemorrhage and it's an ulcer. So callus is a pre-ulcerative pathology. So remember it.
And just after removing, just you just feel the skin where
Smoothness.
it is smooth or not. Otherwise, if it is uneven, so it will
Then
create
again-
further pressure.
Yeah, again there will be friction and more chances of increase in the pressure, and there will be ulcer formation and healing will be delayed. Yeah. आपको पता चल रहा है क्या वो मैडम जो काट रही हैं
नहीं पता तो चल रहा है दर्द नहीं हो रहा है
दर्द नहीं हो रहा वो बोल रहे हैं पता चल रहा है हाथ से पकड़ रखा है पर देयर इज नो पेन सो यू सी दिस इज द प्रॉब्लम पेशेंट को बहुत बड़ा अल्सर होता है पेशेंट इज लार्ज अल्सर एंड दे कम इन योर क्लिनिक वॉकिंग इवन दे डोंट हैव एनी पेन big ulcer huge ulcer and they are coming walking without any pain so always remember it if a person who is coming with ulcer and not having pain you diagnose it as a neuropathic ulcer. If it is ischemic, it's a very painful condition. If it is ischemic ulcer, it's a very painful condition. So always remember.
So you can see.
See
a
what
lot
you're
of-
seeing here, I can see some people are getting a bit frightened, isn't it? This is magnified. It doesn't look so big looking at the foot. So don't get worried, okay? It is not that bad.
Yes. And remember it. One thing I always say, and as the Professor Jude always say, it's a teamwork. It is not that I'll treat diabetic foot, he will treat or you will treat. It's a teamwork. Teamwork of physician or diabetologist or endocrinologist, surgeons, podiatrist,
now
vascular
again
surgeon,
there is
orthopedic
a
surgeon, all
margin
this.
or
So
heart.
always remember
So
it,
we have
and these things doesn't require any OT setting. You can do it in your outdoor clinic only.
If you want to come have a look closer, you can come and have a look. Come inside. Come stand here. If you want to come and see, come and see. Come. It's not that bad. It's looking worse on the screen because it's so big. Okay, it is actually not that bad. Come guys, come and have a look. Come. Yeah, go. Come everybody. It doesn't look that bad when you go close to the foot.
জয় একটা হ্যান্ড কেয়ার করে ইয়েটা কর জুতোটা তোল। Yeah.
So you see, Professor Jude have discussed 3 important points: adequate debridement and infection
just,
control,
again,
offloading,
you just
and
feel
adequate
whether it is
vascularity.
smooth or not.
Adequate
Otherwise,
vascularity was there
this
because we have seen there is a palpable pulses and good flow. Then adequate debridement, she is doing the adequate debridement and probably doesn't looks infected. This ulcer doesn't looks infected. And then third point in the management of diabetic foot comes is the offloading. So she is going to give the offloading, how you can offload the ulcer.
So whenever we see these type of foot,
তোমরা
always-
আগে চলে আসো দেখে নাও আগে আসো না এটা
All-
you will be more comfortable. Go. Don't fear. কি তুমি দেখতে চাও না ভয় পাচ্ছো?
So So not only the foot, you have to check the footwear. Just rotate kore do, ebar samne dekha. You have to check the footwear. You can see there is a very high pressure area at this fifth empty head. Yeah. And always check for is there any
টাচ করে দেখ কিছু ভিতরে ঢুকে আছে কি ফরেন
is
বডি
there
কিছু
any
এরকম আছে কিছু
foreign body
ঠিক করে দেখ
or any this nail
it is
or
not the
anything.
examination of foot only, it is the examination of foot wear is also important. As Professor Jude I mentioned foreign body because that is the source of that is there. Because we have seen in one patient there was nail was coming out of the shoe and that was causing the constant source and infection, got infected, even landed with the great toe amputation. We have seen one patient recently, so that is there. So always remember it. Oh, see it on this screen probably it was looking very big as Professor Jude mentioned, but it's very
So,
clean ulcer, good, no infection, nothing.
So
Yeah.
after just callus shaving, you just clean with the normal saline. As Professor Jude has already mentioned, there is no application of the costly medication or ointment. So we just clean only with the normal saline, keep it dry and just cover with the simple gauze. And now comes to a point regarding the offloading. So
একটা কোথায় রেখে
if
এই ওটা দে তো এলা this is a indigenous technique of offloading which we have developed. I camera সামনে এটা দেখাও তো বাবা কি করে দেখাবে yes so it's the indigenous technique of offloading. What we do, we take the piece of foam টা দেখা এটা foam দে আগে. You see this is the foam, just roll it just like it, roll it and wrap in a piece of gauze and just stick, and I'm going to show you how you'll stick. Just an example I'm showing you. See, if there is an ulcer, hey, focus karo er upore. If there is an ulcer just like that, is the fifth empty head ulcer, you put these two and you see if you will not have these offloading, so then there will be pressure on the ulcer, but you see there is no pressure on the ulcer. So no pressure. Yeah.
Yeah.
On the rest of,
So
that
if you
is-
remember, here is an ulcer, okay? So here is an ulcer, if you remember. So we keep the offloading, two offloading, one just above the ulcer and one just beneath the ulcer. So if you say there is no pressure at the ulcer area.
It is just like this. The example you can are able to see it. It is just like it. So there will be no pressure. If you will not do it, this ulcer is never going to heal. Because if there is a pressure, it's not going to heal.
So
But
how to put?
if the ulcer is on the dorsum, you doesn't require any offloading. Just protection by doing a dressing.
Yeah, microphone.
We don't put the micropore is much easier and the reaction is not there and hair plucking and also it's very safe. And we ask the family members to do it at their home. Yes. And they are not supposed to come. Now they'll come after 3 weeks or like that. So not a regular disease. Just like we teach them. Even in the primary care center they can do. So we have done it.
Mr. Karira, हो गया?
उठ
आप
जाइए.
उठ सकते
कोई
हैं,
दर्द तो नहीं हुआ
ठीक है?
सर आपको? पक्का? So you see, he is not having any pain. So you have cut so much. If you'll, yeah, एक बार खड़े हो जाइए. नहीं एक मिनट रुक जाओ बेटा. रुक जाओ एक बार खड़े हो जाओ. देखिए, अब ये खड़े हो रहे हैं. आप देखिए.
Yeah.
कोई दिक्कत नहीं है? ठीक है. उनको जूता पहना दे बेटा. आप देख ले. Let go. देखिए इनको कोई पेन नहीं है. Why there is no pain after cutting so much? Because he is in neuropathy. He is in loss of protective sensations. So there.
Shubhodip, you can come.
It will a bit advanced case, so you look into it because we are going to give a posterior slap to him, not the total contact cast because it's a rainy season and during that it's destroyed and he's a teacher by profession, so a lot of problems. So we are going to change this. Already he's on posterior slab,
Yeah,
so we are
can
just
you
going
show
to
the
change it.
case number 1? चलिए show करो.
তোমার কত 8 মাস ধরে আছে তো আলসার 8 মাস
শুয়ে পড়ো
কি করে হলো এটা তুমি জানতে পারছো না?
না
মানে মেকানিজম অফ ইনজুরি কি করে হলো এটা তুমি কি বলতে পারবে না? তো কি করে জানতে পারলাম তোমার এই আলসার হলো তাহলে?
এই পয়েন্টার প্লিজ
হ্যাঁ হ্যাঁ। Oh, acha. So you see, what is the history? He is having this ulcer since 8 months. He was not knowing how it happens. He went to a doctor and he told that you have got an ulcer. So again, history, yeah, is a 6 years diabetic. So again, history itself suggests it's a neuropathic ulcer.
Case
Because he was
number
in
one.
ulcer, he was not in pain. Cool.
case
Just
number 1 the
is
pointer
opening
block,
and then
please.
the
এটা নয় কেস নাম্বার 1
these are very painful. Patient just toes in the bed. No, no, this is very important. That's why we see the flow. If you will put a scalpel, then you will do the disaster. Disaster. So always remember. Even
he is,
one thing I tell you, the one simple technique. We do a lot of flexor tenotomies. So in that, first we palpate and we find very good flow, then only we cut the tendon. Otherwise, it will be a disaster.
So he is Mr. Shubhadev Maji. He is শুয়ে পড়ো he is হ্যাঁ
दिखा दे वो
हाँ हाँ एक सेकंड नहीं उसमें करेंगे ना तो दिखा देंगे।
हाँ
हाँ এটা খুলে
কোথা এটা এক মাস হয়ে গেছে না? এক মাস, হ্যাঁ ঠিক আছে। It's a posterior
It's a
slab
slight change,
which we have given. So it is because এখন তো মানে yes, actually I tell you my problem is I started
তোমার স্লাইড চেঞ্জ হচ্ছে না এই স্লাইড চেঞ্জ হচ্ছে না আমাকে গ্লাভস দিয়ে দেন গ্লাভস আর হ্যান্ড কেয়ার না থাকলেও হবে চল হয়েছে চেঞ্জ হয়েছে
উঁচু করে পাটা পাটা উঁচু করো।
So he is only 35 years.
What we have done recently, we have got a immunofluorescence camera. So by that is based on artificial intelligence. So what we do, we take the photograph and by this you will able to know it's a gram positive or gram negative bacteria if it's both. So by that
moleculite.
So this red is gram positive. If it comes green, then gram negative. If both, then gram positive and negative. So we start with empirical antibiotic, and meanwhile we take the deep tissue culture, sand it, and wait for the culture report to come instead of just leaving it like this or just like this. So that's the X-ray देखिए तो सर के देखो.
से एक्सरे है इसमें है
नहीं उनको दिखा
अच्छा हाँ सर को दिखा दीजिए
এটা কবে আছে এটা এটা আছে আপনার
So he
31
is 35 years of age and his diabetes since 8 years and hypertension since 6 years. He is on oral medication and he is presented with complaint of non-healing ulcer on the plantar surface of the great toe of left foot. Yeah. Yes,
Yeah,
sir.
yeah, I
Yes,
can
sir.
understand.
Yeah. That's why we have given this posterior slab.
The front
And thermometer ta de.
and you see that's why temperature difference is
Yeah, temperature difference is 6
it's a
degree.
multiple thing. That's why
6
we have
degree.
put this case there. And temperature कितना 4 degree था
6 degree, 5 degree. 5
oh sorry
Initially it was 7 degree and now it was 5 degree. তুমি এই পাটাও সোজা করে দাও
If you look at the X-ray now, if you look at the proximal metatarsal, he's got fractures there. Can you see that? See, he's got the first, second, third toes. There's a fracture. I can't see the fourth and the fifth. Yeah, so he's got Charcot involving all the metatarsal heads, metatarsals rather, proximal tarsal bones, sorry, tarsal bones. The phalanges, sorry, yes. Um, yeah, so I'll pass it around, you can have a look.
Yeah, you can
Yeah.
change in the presentation,
Yeah.
please. Presentation.
This is the X-ray which was done around on 20 July, 1.5 months back, and this is the X-ray which has been done yesterday only. This X-ray has been done yesterday.
Yeah, you can see the changes are more prominent, yes.
Now it's more
Yes, correct.
So
Extensive damage. How old
we have-
is he?
Huh?
How old is he?
he's
ये
कितना
change
40
अच्छा ना था।
40 বছর বয়স না বয়স কত
35.
35
35,
He's
so he's
35
quite young
years
then.
age
He's
and
quite young.
he's diabetes since 8 years.
Okay, so quite extensive. Type 2, isn't it?
type 2
Yeah, and his ulcer is since 7 months.
this is there
Yeah.
this is the history foot and ankle
Okay.
mode of ulceration unknown as he is telling professional teaching ADS standing thakta he came to us around 1.5 months so at
Okay.
that time we have given the pushti slab and now we are planning yesterday we are going to change it but I thought ki we will show it here we will see the patient here so this there
During presentation, there was a lot of swelling. There was a lot of swelling at this area. So after giving this posterior slab, the swelling is reduced.
temperature difference
And
there
yeah, if you see
Early
the
sharp
temperature
change.
difference,
Yes.
this is there
you can see.
post debridement and pedal and as there was a ulcer so we haven't given
So there
the
is
total
a,
contact cast we have given the posterior slab that's why because there was an ulcer
so this is the digital thermometer, infrared thermometer or glucometer of the foot.
थोड़ा
Okay?
बेटा पाड़ा ऊंचो करते একটু দেখ হ্যাঁ এই যে no we have removed it was huge when came अच्छा and difference you
Yeah.
see a lot of
So-
swelling even after giving this and temperature difference is
Yeah.
कल कितना था 5 degree
5 degree.
हाँ quite
Yeah.
swollen yes कितना है देख अभी
So in this foot,
32.6
32.6,
here
and in this foot 27.6.
5
So
degrees
5-degree difference.
and when he came at the time it was 7 degrees
How long ago was that?
So after debridement, so this is. Huh.
So before that, who was he going to for treatment?
I don't know he came for the first time
No,
at
no,
that time
before that, who was going? Before that, who was treating his foot?
আমাদেরকে দেখাবার আগে কে দেখছিল পাটা
ভেলোরে গিয়েছিল
আচ্ছা তারপর
ভেলোর থেকে ফিরে এসেও ফিলিং ভালো হয় তখন ফোরসাইট বলে একটা হসপিটাল আছে যারা ফুড কেয়ার করে
আচ্ছা
সেখানে পিজির ডাক্তার বসেন
হ্যাঁ হ্যাঁ
তিনি কিছু ওষুধ দিয়েছিলেন
হ্যাঁ
কিন্তু ওইটাকে পরিষ্কার কোনোদিন করেন আমি একদিন ডেকে আমি বললাম এটাকে পরিষ্কার করার একটা ডাক্তার দেখছে
আচ্ছা আপনি ভ্যালোরে কাগজপত্র আছে কি বলেছিল ভ্যালোরে ওরা
তারা কোনো কাগজ দেয়নি
এই ভ্যালোরে তোমায় কি বলেছিল বাবু
স্যার আমরা বলেছিলেন সিএমসিতে দেখিয়েছিলাম
হ্যাঁ
তো সিএমসিতে বলেছিলেন যে ওখানে কিছুদিন ভর্তি হতে
হ্যাঁ
যদি মেডিকেশন দিয়ে সেরে যায় ইটস ফাইন আদারওয়াইজ দে হ্যাভ টু গো ফর দ্য অ্যাম্পুটেশন
কোন মাসে গিয়েছিলাম ওখানে ডিসেম্বর না না what they have told ki we'll admit you and we'll look for it after 4 5 days we'll look into it if it's fine means ulcer become healed or start healing then okay otherwise we will do the amputation
Amputation of the great toe.
Sharkus.
So this is that presentation. This is that presentation. This was the ulcer, and after this debridement, post debridement at presentation, and we did this fluorescence imaging of wound, and there was a gram-positive bacteria, and there was an infection. So we give according to the gram-positive bacteria antibiotic we have given, and next. No, after 2 weeks follow-up, this was the status, and
আর সব থেকে বড় টেম্পারেচার ডিফারেন্স কমে গেছে 7 থেকে 5 ডিগ্রি চলে এসেছে So instead of 7 degrees, it become 5 degrees now. So he's better. So actually he came yesterday. So I told that you come during the workshop, so we'll show this. This is, and we'll take your opinion also. Ki what further can be done.
And this was at the 4th week.
I've given it in 4-5.
And this is at the 6th week. This is at the 6 weeks. And today he came to us. There is a, you can see there is a lot of callus around the ulcer. So we will debride it, and after debride we will give the posterior slab because he has also the charcot foot. So we will not give the
Total contact cast
technique offloading.
So the question is, you're giving posterior slab. Does he take it out at home?
No.
So it is fixed.
Compliance is very good. Do the dressing and then close it. That's all. কত সময় খোলা রাখো? আধ ঘন্টা? 1 hour in every third day. তাই তো? नहीं रात्रे तुम्हें एटा नहीं घुमाओ तो? Yes. Compliance we have assured that compliance, otherwise it could have not worked. Yeah.
So as the pulses are palpable, so we are able to remove the callus, and you see the ulcer is red. So we know this is the neuropathic ulcer.
I'll show you.
एक part गुटिए ना.
MCR insole, because instead of changing every week, because cost is a big factor in here, so I change it every 6 weeks, and so we are given a insole, so it stabilize, and so MCR insole.
So there is a emaciation of around the ulcer because today is there is too much rain, so probably some water goes inside. You can see. Blade number 15. Yeah, you just remove the callus.
ক্যামেরা ঠিক করে ফোকাস করো বাবু, ও শুধু হাতই দেখা যাচ্ছে।
And as it is the chronic ulcer, you can just make it turn to active one. So you just curate the ulcer.
All the chronic ulcers should be converted into the acute ulcers. So if they are, then curate it.
So this is the curator. Okay, you can see this is the curator. Yeah. This is the curator. You just curate the ulcer to make it.
But already
active.
it's a granulating and healthy looking ulcer.
Yeah, just
So
mildly
nothing.
you just
Bas.
curate.
I don't think you require much of curation in this patient, because otherwise you are going to remove the healthy granulation tissue also. So don't do much.
Just dressing the
Because, once you see, you will say
Normal
it's a
saline.
neuropathic ulcer. You will never think of having the Charcot's. So that's ulcer.
So we just put the simply dry dressing after cleaning with the normal saline.
Think of osteomyelitis from the beginning.
No.
It's again neuropathic, so
Again
there is no
neuropathy,
pain.
there
Even
is
you
no
cut
pain.
his great toe, he is not going to feel it.
This is
So
very
we make him
simple dressing,
understand
and
कि
after
every
dressing
third day
you
change
just
the dressing, because in total
think
contact
about the
is
offloading.
mainly this rainy season they will dust that, and it's a problem, and then remove it, and cost is a big factor, so that's why we do this. That is the এটা কেটে কাঁচি দিয়া জয় কাঁচি বড়।
So for offloading we will give the posterior slab. This is a Dynacast preload. It is just a fiber
দেখিয়ে দাও।
cast. Yes, it is a fiber cast, and it has 7 layers of the this cast. Okay, I just remove
This is a
it.
fiberglass cast, okay? So that she is going to show you how she will do the fiberglass cast in this patient. And actually ideal is, according to the international standard, every week or maximum every 3 weeks, but due to the cost constraints, we are doing every 6 weeks. If it is destroyed, damaged, then we change in between also.
First
And
you
he
use
is
the-
going to require this cast not less than 6 months maybe. So generally it requires 3 to 6 months. So 6 months is the usual time. I think Ed will comment more on this particular issue.
Yeah, so normally we put at least for 3 to 4 months. We do assessments every week in our practice, and once the temperature difference is less than 2 degrees, then we take them off the cast and put them in special footwear. But most people require at least 3 months, but like Ghanshyam said, 6 months to 12 months sometimes.
So we are using this type of MCR insole, and just the ulcer area, we just scoop this area. Okay, so there is no pressure at this area. Just we already cut it just yesterday, and to just reduce the time, and this is the Dynacast preload.
It's ready to use actually. It requires very less time. In total contact cast, it requires a lot of time, and during rainy season, this is a big problem which we faced since last more than 23, 24 years we are practicing diabetic foot. So if it is water goes inside, it will be damaged. Then you have to remove it. So that is there. So because
So
it's a
just according to
but
site,
compliance,
we can-
as Professor Ad have mentioned, compliance is very important. অনেকজন কি করে বাড়ি থেকে খুলে দেয় আর তারপরে ঘুরে বেলায়, so that should not be done. It should be, he have to wear this cast all the time. That is very important. You have to ensure that he is wearing the cast all the time.
So we can just cut according to his size. So margins are margin should be very margin should be very smooth, otherwise it harms him. Just give a little bit normal saline. And just stick to this.
Because we are giving the insole, that's why we are doing all these exercises. Otherwise directly you can put it. But to give the more stability, because you see this is the older one and it is having more stability on account of this. The insole is inside.
Now you can
Because it will go inside. So just to give it,
Yeah.
to give more stability. Just.
So how will he take out that bandaging at home?
yeah.
He can do it himself, or somebody does
No,
it for him?
not himself,
Okay.
by the family
So
members.
you'll teach somebody in the family
Yeah.
to do it, yeah.
এর ড্রেসিংটা আপনি করেন কি ও কে করে? আপনি করেন তো? ও আচ্ছা।
So at the
Even
heel
for
area,
offloading, we train all the patients' family members.
so it should be 90-degree angle, otherwise
Always
patients are
remember,
not able
এটা
to walk.
যদি এটা হয় তাহলে ওটা হাঁটতে পারবে না পেশেন্ট। It should be 90 degree. It is not 85 or 95. It should be 90 degree. So make it, আর না তো কি করো মানে এরকম করে দাঁড় করে দাও তাহলে ফ্ল্যাট হয়ে যাবে। আর তারপরে ব্যালেন্সিং করার জন্য অন্য পায়ে তোমাকে জুতোটা একটা অ্যাডজাস্ট করতে হবে। আউটার সোল না তো ইনসোল দিতে হবে যার থেকে না তো পড়ে না যায়, হ্যাঁ?
So it should be at 90 degree. So let it be get hard, and in the meantime I will show you the footwears. So these are the diabetic footwears.
The footwears which Professor Jude have shown is in his presentations. So one is total contact cast he was showing, and he have shown the air cast also, and the footwears he have shown. So now she is going to showing the footwears.
So these are the footwears. So you
Footwears,
can see
I tell you there are 3 types of footwear. One is preventive, another is therapeutic, and third is customized. customized footwear is required by hardly 5% of the people, not all. Then comes therapeutic and then the preventive. Therapeutic, as for him, it is therapeutic. It is not customized, it is a therapeutic. Customized, যাদের ধরুন আঙুলটা বাদ গিয়েছে, পাটা টেড়া আছে, or মানে এটা কিছু আছে, deformity আছে, ওদের মধ্যে they will require the customized footwear, and that is less than 5%. Rest others are requiring, just like what he is using the therapeutic footwear, and then the preventive. ধরুন আমার কিচ্ছু নেই, আমি ডায়াবেটিক, ধরুন আমার LOPS আছে, loss of protective sensation, তো I'll require the preventive footwear. খুব ভালো যে স্কেচার শু হয়, আগে থেকে চোড়া হয়, ওইসব পরলেই কাজটা হয়ে যাবে। ওকে, ইয়া রেখা।
So the footwear in diabetic should always be velcro adjustable, and this is the toe box. The toe box should be wide enough so that all the toes to be lie in this way. So there is no overlapping or no overcrowding of the toes, and the heel counter should be rigid and the outer sole should be thick and tough, so there is no foreign body may prick. And regarding the insole, regarding the insole should be thick enough. It is 8 to 10 mm thick. Generally in our footwear there is no insole, it is very thin. So in diabetic patient it should be thick to reduce the plantar pressure, and not only reduce, it will redistribute the plantar pressure. So some common, these are the footwear, like if the person have ulcer in the mid foot, then they can wear this type of mid offloaded footwear. So there is no pressure at the mid foot. And these are some front foot offloaded. You can see there is no sole. So if the ulcer is in the great toe or first empty head, you can give this type of footwear. So there is no pressure in the front foot.
Rekha, who makes these footwears?
Yes, sir. There is very different companies like.
So it is ready to order.
Yeah.
Okay, and you got different sizes: small, large, medium.
Yeah. And this is the hind foot offloading. If the ulcer is at the heel area, then you can give this type of footwear, but always ask the patient to walk with a walker. Otherwise, patient may fall in the back. Otherwise, patient may fall in the back. So always ask the patient to walk with a walker.
This is a very important aspect. Always remember it.
And this is the surgical footwear. Whenever there is a large dressing, you can provide this type of footwear, and also with this cast, and also
you can
with
call
this
it as the cast shoe also. When the patient is on cast, then you can give this sort of footwear. This is a smaller one for him, so you give the larger one.
You can see there is a large velcro, so you can adjust according to foot size. Silicone insole.
Silicone insoles is very good in reducing the pressure, but only thing is the cost. One pair of silicone insole costs around 2,000 rupees, and it will bottom out within 3 months. So that is a problem. So that's why we advise to very less number of people.
And this is the podiatry kit. You can see there are a lot of instruments. I have shown you. This is the curator. Okay, and this side you can use as a probe. Sir has already shown we can do the probe to bone test to show whether there is osteomyelitis or not. And this is a very important tool in diabetic patient. There is a very hard and thick nails. So by this instrument, this is a nail niggler or bone cutter, you can say. So by this instrument we cut the thick nails. Generally with the simple nail cutter it is not possible. And this is the tissue nipper. Generally the cuticles and the nails are attached with the skin, so you can cut with this instrument. And the nail filer, in diabetic patient always cut the nail just straight away, and the margin should be filed with the nail filer. So now we we will open this slab. Now, you can see there is, it become hard. Aste, oh, aste. Aste, shoot. So it gives the shape of the patient foot, and we will cut the ends. Okay.
She is going to cut it, and it is reshaped according to his foot size.
The cut
And it is there. So it's a time-taking process, I tell you. So believe me, I think Professor Jude is the right person to answer. Hardly less than 5% of the clinics across the globe are using the total contact card. You are using it, but yeah. So around the world, globe, I think hardly 5% of people are using this car. So that is there. It is a time consuming. And second thing, person should be trained to make it. Otherwise, there might be iatrogenic ulcers. Iatrogenic means the caste-induced ulcers might be there, and will fit in a lot of problems. So you have to be very cautious about all.
So you can see, I will just, it was,
this sort of modalities to offload. So that have to be remembered.
Training is very important.
Very important, very important. So meanwhile, if you are having any questions or comments, because Professor Jude is here, so it's a unique opportunity for you to discuss with him your any question. তোমরা যদি বাংলায় বলতে চাও বলো, I can translate, no problem. একটু ভয় মানে কি মানে একটু মানে হই পারবে না, don't be shy. মানে তোমরা জিজ্ঞেস করো কিছু তোমাদের কোয়েশ্চেন আছে, পেশেন্ট এসছে কিভাবে কি করবে সেটা, I think Professor Jude will be happy to answer your question. Yes, anybody, please. Yes.
I would like to know what is the very first sign of diabetic trouble in the foot. For a person with diabetic for a long time, like say 10 years, everything looks fine from the outside. So what are the basic first signs that they realize that something is wrong with the feet?
Very important
You must
question.
remember that the first sign is no sign. Okay? Very often people who got neuropathy will have no signs, no symptoms at all. That's why it's important that they should have regular foot examinations, because they will not come and say, I've got a problem with my foot. I've seen patients come into clinic, you take the sock off and the toe will come off in the foot, and they didn't know they had gangrene. Because they had neuropathy, they didn't know they had gangrene, and the toe just came off, what we call auto amputation. Okay, so yes, but the signs they can have or symptoms they can have is numbness, they can have claudication, they can have painful neuropathy, but quite more often than not, they have no signs at all. There are no symptoms. So unless you examine the feet, you may not pick up or identify people who have got foot problems. So people have to examine their feet every day. They need to know what to look for. So we tell any swelling, any redness, any discharge, any breaks in the skin. Those are the 4 important things that people should be looking for. There have been studies where we've given people neurofilaments and told them to do home assessments for neuropathy. That can be done also. We can also use a mirror when they to look under the feet if people can't examine the foot. So we ask them to put their foot on top of the mirror.
So there is no pressure at this area.
Very nice. Very well. Very good.
So this is the posterior slab. Now we can tie in his foot,
So we are using just this.
and there is only one problem. After 6 to 8 weeks, it becomes lengthened. You can see this is the foot at right now, and you can see this is approximately 2 inches more. Yeah, reduction, swelling.
Healing, how much time it will take?
স্যার এটা আপনার খিলের ক্ষেত্রে মোটামুটি 3 মাস মিনিমাম লাগবে।
পাঁচ সোজা করো, পাঁচ সোজা।
আরো 3 মাস লাগবে, কেন এটা যেরকম কেন কি টেম্পারেচার ডিফারেন্স এখনো বেশি আছে 5 ডিগ্রি।
এন্ড বাঁধার সময় সবসময় অ্যাঙ্কলটা যাতে ফিট হয়ে যায়।
একটা ইনজেকশনও দেবো আমরা, ইটস এ কস্টলি ইনজেকশন। আপনার সঙ্গে কথা বলবো, আপনি করে ছেলেকে আনবেন, আপনি চলে আসবেন আমার কাছে, তাহলে বুঝিয়ে
So he's on his feet all the time, isn't it?
Yeah.
So if he can do
স্কুলে
things
তো
where he's
মানে
not
দাঁড়িয়ে
on his feet all
পড়াতে
the
হয় না,
time,
ও তো বসে
yeah.
পড়াতে পারবে না। হ্যাঁ।
If he can sit and do his lessons, then he can go back to teaching. Yeah.
বলছে কি বসিয়ে পড়াতে পারবে, দাঁড়িয়ে পড়াতে পারবে না।
No, the problem is he has to lift a 5th floor or 4th floor or 3rd floor. So that is the problem. There is no lift.
No lift,
And
okay.
there is he is a school teacher of in a
Yeah.
village.
Okay.
So lift is not is there. So
Yeah.
in sometimes in the 1st floor, sometimes in the 5th floor. So
Yes.
it is not possible.
I think so, yeah.
ওই ইনজেকশনটা আমরা দেবো, ওপরে কেমন থাকে তারপরে উইল ডিসাইড। আমরা তো ভুলে যে ওই সময়টা
এসো শুভদীপ চলে এসো।
Okay.
Give a big hand.
Yeah.
For coming and cooperating with us and giving the knowledge regarding
Thank you
this.
Shubhadeep.
So you can see how he's walking now. There's no ankle flexion. That is very important.
Very important.
Yeah.
And after giving posterior slab, we always give the footwear in another foot and balance the with the both foot. So otherwise, he is not able to walk. So I am finished.
Questions
Okay.
or comments
Well done.
from anybody?
Can you give big hand to Rekha first for a very good job. Fantastic. Well done, Rekha. Any questions? Indrajit, you want to say something? Indrajit? Yeah, sorry, Noel.
If there is a poor blood circulation, then what do you do?
So somebody's got poor circulation in the foot. There's always a debate whether we can use contact cast or in this case back slab on that or not. There's one study that was done in the Netherlands where they showed people with ischemic ulcers, you can also use contact casting. But those people require more frequent foot assessments because sometimes the cast can cause damage to the foot. So you can still use cast if somebody's got a neuroischemic ulcer, but they need more frequent foot assessments to make sure it's not causing any damage or causing any harm. So the healing in the Eurodial study, we showed that people with neuropathic ulcers without infection, almost all the wounds healed. People who had infection, 85% healed. This is healing in 1 year. And those with ischemic ulcers, it is about 60 to 70%. So healing always is slightly worse when somebody's got an ischemic ulcer compared to a neuropathic ulcer. Okay? Any other questions, anybody? Any questions? Yes. So, Rekha, how will you take, Rekha? So in the UK, because we give them total contact cast, they cannot take the cast off at home. We give them special plastic seals around the foot. So they can take not a bath, they can have a shower. So they can then normally have a shower and we put a seal so it sort of holds around the cast so water doesn't go inside the cast. Okay? Any more questions, anybody?
Yeah. What is question? बोलो. हाँ. नहीं बोला. आपको कुछ पूछना है सर?
No? Anybody else? Indrajit, you got anything to say?
Actually, I have something to say that since we are doing field work for the last 18 years, education in a hotel room and execution in the field is something different. So I always find some ways to execution in the field. So I discussed with Dr. Goyal also. From our organization, we are planning to initiate an diabetes foot care screening van if we get support from you people. Because I alone can't do anything. I need your support, your education. Otherwise, this workshop meaningless. Simply meaningless. So I urge upon you please join hand with our organization. If you get the support, Professor Red Jude is there, he will provide support. Dr. Goyal is there, he will provide support. Dr. Rekha is there, she will provide support. I need your support. Spend some time and disseminate the knowledge what you learned from this hall. Then ultimately, this type of workshop will be fruitful. So with these words, I would like to invite Dr. Sujay Majumdar, our Vice President, to say a few words. I didn't get the response from you people. That's my experience over the last few years. At least say something. Can you spend a few time of you for the society? Because yesterday we went to the Sundarban. Medidi will describe the thing in front of you. Before that, Dr. Sujay Majumdar, our Vice President.
To start with, apologies for my delayed appearance because I was stuck in the hospital duties. I was on call today. So, heartfelt apologies for that. And I really missed a great session, particularly with two of the stalwarts in this profession, Ed and Dr. Goyal. Just to say that, as we all know, the diabetes foot is one of the most neglected parts of diabetes management. I think we all know about it. We hardly spend any time in a day-to-day clinical consultation to have a look at the foot. And I still remember Dr. Goyal actually used the word, when we were talking about diabetic foot, a word called apadomastaka. That means, this is a Sanskrit word which means starting from the head to the foot. And when we're treating about diabetes, we have to start from the head and end with the foot, or I should say the other way around, start with the foot and end with the head. Because head is something which is always visible to us, but not the foot. So that is one part of the story. Just a few things about our Sundarban trip yesterday, where we basically found out that of the 14 patients that we saw, nearly 6 of them had undiagnosed diabetic foot problem. So you can understand in just a sample of 14, if the number is 6, you can understand what the prevalence can be throughout, if you look at a population of, say, 3.5 lakh people. So anyway, without wasting much time, I would invite Dr. Mary De Cruz, our other Vice President, to give the final vote of thanks. Mary, the time is set for you.
Thank you, Dr. Sujay. And I'm also sorry that I could not make it in time for the program, but it was excellent. On behalf of DAY, I would like to thank Professor Edward Jude from UK, a world-renowned authority on foot care and how to solve the problems, Dr. Ghanshyam Goyal and Dr. Rekha Agarwal for the excellent work they are doing in the eastern part of India and available for so many people. I'd like to thank you for conducting this workshop as a practical approach to diabetes foot care problems for the diabetes education and educators and also for the primary care physicians. Yesterday, on 31st August, Dr. Edward Jude, Dr. Sujay Majumdar accompanied our day team to Gosaba, Bali Islands in the Sundarbans, where there are more than 3 lakh people staying in about 9 islands of Gosaba. Mr. Indrajit Majumdar, with his passion for caring for diabetic patients, particularly the underprivileged who cannot reach specialty care, made arrangements for a diabetes boat which actually functions right through the year and makes a monthly visit to the islands. And these different islands, they have access to the people who can get their blood tests done, blood pressures measured, and also foot examination is done for them. We'd particularly like to thank all the participants today because without you, we cannot reach out to our patients who are out there in the villages, in the other areas. Our partners, ERIS, for their patient care initiatives and support. And we urge you, Professor Jude, to please help support DAY and its initiatives to reach out to patients. With this, I'd like to thank you, and please join us for tea and snacks. Yeah, thank you. boat we call it. This has got our banners on it. So this is where we went, and there were a lot of ladies and gentlemen, about 20 of them waiting to be examined. This was inside the boat where Dr. Jude helped to examine some of the patients who had come. They were diabetic, known diabetics with foot problems. They were all examined, advised treatment. And here is an old lady, I think she was the eldest one there, she was 79. And boat because we were going from to the different islands. So in Gosaba there are 9 islands, and there are about 3 lakh people in those islands. So from the main center at Godkhali, we reached Godkhali in 2.5 hours from Calcutta, and then from there to the island took us about 45 minutes. So these were the patients who were examined. In fact, like doctor said, there were 20 people, and I took their pressures. Of them, 18 had high blood pressure. And everybody had blood sugars, yes. And almost all of them had knee joint problems. We don't know the cause. Severe pain in the knee joints, cannot sit down at all, and body ache. You know, like that day it was very hot. Yesterday was humid and hot. So this is Dr. Sujay is there, and and then they were going for diet counseling, and you know what they could make changes in their food and diet. And these were the last of them before we left the place. So
how they are getting the medical help?
that's the sad part. There was no PHC, nothing over there. I wrote medicines and gave, they can't get them there. No antihypertensives. So, একটা ভিডিও ছিল না, সেটা চলবে? একটু ভিডিওটা দেখিয়ে দাও। Very sad.
Not playing video? नहीं वहाँ से नहीं हो रहा है क्या?